introductions. I think my lead's outside. So this is Dr. Panchal coming from Tampa, so we're sticking in Florida. Thank you for coming over to the East Coast. And we have Matt, and we're going to be showing the VYRSA system. So I'll let you get started while I go find my lead. There it is coming in right there. And I think we have some slides that we'll start with. Yep. And I'll give you control, and I'll be right back on screen.
How do you get the slides? All right. Okay, so I'm going to talk about the SI joint fusions. There's a different approach. Can we go back to the let's go back to the first slide. Okay, perfect. Thanks. So again, with SI joint surgery, there's a lot of different techniques. There's systems where you're involving just fixation of the joint. There's interpositional implants, and there's also a true fusion where you have to decorticate the joint to achieve a fusion. We're going to talk about that method. We're going to have a decortication of the articular portion of the joint, and then we're going to have a rigid fixation to allow that fusion to develop over time. So this will be an approach where we're going to have the decortication coming through a posterior inferior approach, as you can see on the left-hand side, where we have our dilator there. We have a box cutter there that's going to be able to create that decortication and have that bleeding bone edge bed. Then you're going to fill that space with a flowable graft. In the past, we would end up using perhaps cortical implants in there, but with a lot of the coding changes, we now have to avoid structural allograft. So we're going to end up filling this decorticated space with a flowable allograft, and then go ahead laterally to place screws to provide that fixation. You can see from the slides over here, you can see where that instrumentation sits. A lot of physicians who may be thinking that the SI joint ends where that ventral sacral line is, actually you have to think about that when you go further laterally away from the midline, that joint actually extends much more anteriorly. So this is where you're going to be able to stay within that joint space. The borders of the SI joint on the superior edge are going to be that alar line, and so we're going to be talking about the alar line, the ventral line, and the posterior line of the sacrum as some of our landmarks for instrumentation. And then you can see on the image on the right-hand side, you can see where our fixation is going across that anterior portion of the joint, going across the bed that we decorticated, so you're going to have compression over there, which is another important piece for fusion to develop. And again, on this next slide here on the left-hand side, the green line outlines the actual articular portion of the joint. The middle image there shows you where the anterior part of the joint is in yellow, and posteriorly you have that ligamentous region of the joint where often there's a gap between the ilium and the sacrum. There's a dissected image here just to the right of that, which again you can see where that white image is where the articular portion of the joint where our hardware decortication needs to occur. And then on the image all the way on the right, that green line represents the anterior part of the joint, which is what you'll see when you look at an inlet view.
And I think this is a great slide to show, if we're looking for a fusion, right? And VYRSA is a parent company. You guys work more in the fusion space.
Yes.
In the spine world. And I think this is how a fusion is done elsewhere in the body.
Yep.
Direct decortication in a joint, compression across that joint.
So some of the people on this call may know of VYRSA. We've been in this space doing a standalone allograft, but our system was actually designed originally for use with supplemental lateral fixation. So what we're talking about today, what we're teaching today, is really more about the lateral fixation. But as we move into lateral fixation with many of our interventional spine physicians, our plan here is to offer a system that's going to allow you to continue to do that familiar posterior approach for decortication. That's going to allow you to remove that cartilage that you see here that's going to prevent a fusion. It's also a source of pain. It's a pain generator, that cartilage surface in the joint. And so our instruments will allow you to do both. And so that's what we show.
All right. Now, when it comes to how much of a bed you can decorticate, one of the other systems in the market allows you to decorticate approximately 50% of the joint space. I was a PI for a multi-center study where we involved 250 patients, and at 1 year we were able to show on CT scan a 70% fusion rate. This approach here may potentially allow you to decorticate up to 80% of that articular region. So hopefully you'll have a larger fusion bed to develop and may increase your success rate. And this is something we'll need to study going forward. And again, here, after we decorticate that space, we want to have transfixation of the joint. Again, that's been clarified in terms of the language with the new definition of the 27279 code, that you have to enter through the ilium, go across the joint, and then enter the sacrum. So this is going to be consistent and compliant with that requirement. This example, what we're using here is a lag screw, so this will allow us to create a compression force. If you look at the graph on the right-hand side, this is the amount of force measured in newtons with this lag screw in comparison to a dual-pitched threaded screw, which would try to draw the ilium and sacrum together. The black line represents the dual-pitched screw, and there's a limit of how much force you're able to get. And the blue line represents the lag screw, and it has a much greater amount of compression force. Again, here in this image here on the left-hand side, we start thinking about, with the anatomy, what are we trying to do? That anterior portion of the joint, you can see on the left with that green line, shows that the average distance between the ilium and the sacrum is about almost 1.5 millimeters. Whereas if you were going through an oblique approach through the ilium, you're going to have to go across that gap portion of the joint. Average distance in that gap is about 5.5 millimeters. And if you have a significant force over that, can you cause a fracture of that iliac wing? And we've seen some posts regarding some of these cases where that's occurred. So if you're going across the area where there's very little space between the two bones, you're going to avoid that fracture risk. And also that portion that you're going across for that lateral approach is the densest portion of the ilium and sacrum. So you're going to have greater fixation with that and less likely to have loosening of your hardware.
So as many interventional spine physicians are looking to evaluate new methods that utilize lateral, one of the reasons being for the change in coding that has occurred.
Yes.
There's different options, there's different screws, there's different approaches as well, including the posterior oblique versus the true lateral approach that we take. And these are some of the anatomical considerations that you'll want to evaluate when you're choosing that approach. That's what we're talking about here. I think we have one more.
Yeah. So again, this slide here again gives you some more examples of where the forces are with axial loading going across the joint. Again, you should reiterating that with that lateral approach, that you're going across where the bones are most closely approximated versus that posterior oblique approach where you have increased force and perhaps more movement of the ilium. That if you over tighten the hardware and extend too much force, can you cause a fracture? Yep.
So some of the benefits of the true lateral approach that have been noted in different studies and in literature are, you're going to have a shorter trajectory with this true lateral approach, a smaller gap, as we mentioned, between the bone surfaces. You're going to avoid damage to that interosseous ligament dorsally, which is really important for maintaining the integrity of the joint and stability. You're going to be going through greater bone density with that trajectory, and so that's going to lead to less risk of implant pullout, low risk of sacrum or ilium fracture, and overall you're going to have a better chance of a successful fusion, less risk of pseudoarthrosis.
I think that's one thing that's big for the field is, are we going to be able to prove fusion, right? If we're going to use a fusion code, we have to be able to prove fusion. So a lot of, innovation is sometimes driven in different ways. This innovation that's coming with a lot of the lateral approaches out there is been out there. You guys have had this screw for a little while, but now we have to go there because the coding is telling us to, and that's okay, I think, because I think in the long run, a few years down the road, we're going to be able to show a pretty good cohort of actual fused SI joints getting these new techniques. So I'm excited to see that.
Yep.
Should we?
And one last point is that when we're doing a lateral instrumentation, people are concerned about possible risk of a hematoma.
Yes.
So if you look on the image on the left-hand side, this is a 3D reconstruction of a CT angiogram, which is what I get routinely for every case in preparation. So I can determine where the SGA is running. And if you can see in the imaging here, you'll see this SGA divides into a posterior and anterior branch, and that posterior branch has some variability. So right now it's out of the way from where if you look at the borders of the joint space would be. So those three green lines represent the alar line to represent the superior border of the joint space, and then you have your ventral border of the joint and your posterior border of the joint. And then if you look at that image in the middle, You can extend, and again, that green line could extend a little bit more anteriorly along the edge of the, a lot closer to that sciatic notch, but that's going to be the joint space. So right now, usually the artery is out of the way, but there are a small number of individuals where the artery will take a more posterior turn, and you may want to alter the angle or the placement of your hardware to avoid that. So having been doing lateral approaches since 2015, I have not had a single bleed, but I attribute that to the preoperative planning.
I think that's huge. I mean, we aching on that on and on and on. As interventional spine, you have to be surgeons. You have to get the preoperative data. You have to get the preoperative imaging, and you have to look at it, and you have to have a plan. Yep. You can't just show up at the ASC or at the hospital and just wing it. Yep. It's not with these procedures that are out there. You have to have an idea of what you're doing before. That's great. I love it.
So great. With that, we'll get started.
All right, did you bring the C-arm in?
So we'll do the posterior approach very briefly. We kind of have things already set up in place.
AP?
Yeah, go to an AP, please. So again, the images that we're going to need to be able to do this procedure safely, we'll have to do an outlet view so you can see where the foramen are. We're going to do an inlet view so you can see where the anterior margin of the cortex is so you don't violate that. And then again, part of the instrumentation will be advanced in a lateral view as well.
Take a shot there.
So if you could first go to an outlet view, so go 30 degrees over. You want to make sure your S1 end plate is lined up. That way you know that you're in the true outlet view. And you can see the foramen there. I've already placed the pin and advanced laterally to, since we have a limited amount of time for when you're doing the lateral approach. And we want to try to, ideally, if you have enough room, try to get above the foramen for the first screw, and then the second screw would go between the S1 and S2 foramen. If you go to an inlet view, this will let you see the anterior margin of the sacrum. And then again, this goes to make sure that you can avoid violating that. Now, if you can go, can we get that image? So now, if you look, how many degrees over are you? 30. Go to 25. Because you see a little bit of a double image for that anterior margin, so that's not a true inlet view. So now you can see that the anterior margin.
You can point that out maybe with the other pointer.
Yeah. See right there? Yeah. So that line is the anterior margin of the sacrum, and then you can see how it curves over. Let's see, picture. Picture again. Picture again. So this is the anterior margin of the joint there. So as long as our instrumentation doesn't violate that, we'll be in a safe trajectory.
Yep.
Now what we'll also do is I want you to show them the joint that doesn't have any instrumentation. So if you can rotate 15 degrees over, and we'll look at the right-hand side. So when we look at the joint over here, picture again. Can I see the floor image, at least on one screen?
Maybe put the floor image big for a little bit.
The picture. Okay, so now this is the joint line that you're looking at. And you can see how it makes a turn. And so, picture again. So where that point, can we see that floor image? Right there. So not at the point of the turn, but just slightly inferior to it is the typical place to place your initial pin. So that would be, and that's what we're going to do. So now if you look at the other side where we place that pin.
I think one thing that I want to point out is look at where the C-arm is, if you can see it. So what's the degree tilt towards us about? 15? And what's the degree tilt towards the feet?
25.
I think that's big because a lot of people, the degree tilt to the feet, they're usually more AP, I see. Right. And I think it's more important to get that obliquity towards you and also that caudal tilt that a lot of people miss when they're starting. It makes the procedure more precise.
It helps with our approach, and this is an inferior inlet approach. This is the approach that most physicians were trained to do their SI joint injections.
Exactly.
You have less interference from the PSIS than, say, a more posterior oblique, contralateral oblique approach that is used by some of the other graft companies in this space. And this allows you direct access into that articular cartilage surface that we're talking about in the slides, and we'll see that.
If you try to instrument more superiorly sometimes there's so much overhang of the iliac crest that it forces your instrument to go at such an angle that your implant ends up in the middle of the ilium instead of actually staying in the joint space.
And I think that's one thing that when I'm teaching my fellows about just the injections even, is they wonder why they hit the ilium. I was like, it may look good, but there's a bone in the way there. So really get that tilt to the feet.
I'm trying to get intra-articular.
Yes.
Not peri-articular.
Intra-articular. We're actually doing a study on that right now.
And rotate 15
How often
degrees this
are
way.
you intra-articular when you think you are? So that's, I think that'll help the space a lot.
All right. Okay, so now we prepped this prior where we placed the pin. If you could go now to the lateral view, that we can see how far it's been advanced.
So we put the pin in, and what's the second piece there?
That's going
So
to be a
that's
joint
the-
finder.
Yeah.
Perfect.
It's an initial dilator. That'll be followed by a working cannula.
So we see the joint finder there. In the joint, we're in the joint, right?
Yeah.
So I think we're going to adjust this because the pin looked like it got shifted during the last demonstration, since this model's been used for more than one technique.
Yep.
That's a
Good.
picture.
So that angle you have shooting more anterior than some people would like, I think. But if you really know, like we talked about before, where that joint is, you're safe. I think that's one thing that it's hard for me when I'm teaching my residents and my fellows. You're safe there. You can cross that anterior, quote unquote, line of the sacrum.
And one way to see that is when you're in your inlet view and you can see how that joint curves more anteriorly going lateral, right? So that inlet view is going to allow you to know very definitively what your safe zone is.
So now this joint finder is tapered, so you'll have a thinner portion of get it seated in the joint, and where it tapers will you'll feel a change in resistance when you're right at the joint level. So that's as far as you want to advance that. Then you'll put a dilator over that. Now this dilator has teeth that they're marked for which side goes to the sacrum, which side goes to the ilium. So that way you're seated, you want to have the shorter tongue more inferiorly. So then you're going to place that over the joint finder. Picture. And then we're going to go ahead and then tap that in until both tongues are completely engaged. So we can advance that just a little bit more. Yeah, I'm going to advance this a little bit more.
Picture.
Yeah.
Which can happen.
Yep. Okay. So now we'll be able to pull this out. Now, in a case, this may have a significant resistance. So what you would normally do is you would put this cap over your joint finder, and then you would use a reverse slap hammer to remove it.
This is the fellow's job. He gets to do the slap hammer.
And you take this out with the slap hammer. Usually the pin will come out with it. Sometimes the pin will retain, and you just may need a curved clamp to go in and pull the pin out. Now, what you want to do is you can also look down the barrel of the dilator. So once you go back up to that inferior oblique inlet view, so you can kind of just sort of go down the barrel of the dilator this way. You're going to have to reduce the angle a little bit this way. So just looking down the barrel. Picture. And what you do is rotate towards you a little bit more. Picture. A little more. Picture. Okay, and then maybe you just go towards the head just so slightly. Picture. All right, so when you're doing this, you'll be able to then see where the footprint of your dilator is. Before you start your case, you can also place the dilator upside down and mark on the skin where it is, make sure that you're not going to be going into a trajectory that would be too far anterior.
And your incision for the case, are you doing a cut down? Are you doing the incision first? How do you
So
do it?
I'll place the pin first. First I'll make a stab with it, so again, you're not dragging any dermal tissue. Place the pin, make sure you're satisfied with that, then I'll make the incision. And make incision long enough to fit the dilator. And then
So in our cases where we're using the posterior instrumentation and we're concerned about being oriented with the joint line, this view here, it's not perfect on our screen now, but you can tilt that image over the mouth of your cannula and you'll see that joint line running through the window, so you know you're right in line.
And also, just like we had a 15-degree rotation to be able to look down the joint space in that inlet view, you do the same thing at the outlet view. You're going to see the joint line and make sure your instrumentation is still in the same orientation from that standpoint.
That's right.
Then from the lateral view, that way we can see how far we're going to be. So let's take another picture there. We're going to put a drill guide in first. We're going to have 3 channels here. Picture. Now this drill bit will allow us to drill up to a 50 millimeter depth. So with that, you'll be able to see how many segments you'll be able to cross. Picture. So now, as we go ahead and advance the drill bit, take another spot. You'll see it extending out. And in several of the cases, I'm able to, with this 50 millimeter drill bit, decorticate up to the midpoint of the S1 segment. So therefore, you can get a fusion that develops across S1, S2, and S3. Picture. Now, can you place the floor image on the right-hand screen so I can see the bigger image? Okay.
Where's your stop? Where's your stop line? Lateral image.
All right. Your stop line is going to be your alar line. So I'd like to have a larger image so I can see the alar line clearly.
Could we bring the full image?
There we go. Okay. So now you'll see right.
Tough to point out, but yeah.
Picture.
And just to clarify, you would not have these pins in laterally when you're doing this. This is just for demonstration.
Yeah. Okay. Picture again. Picture. Oh, I need that floor image. Picture. Let's go this way. Okay. Picture. This is where the border of that alar line is. Okay. So you don't want to confuse the joint space where the S1 promontory is.
So you're safe to drill up to that line.
Up to that line. Okay. So I'm going to take this down just a little bit further. That pin that I already put in is in the way a little, so I'm going to stop here. But otherwise, I could extend this further. Okay. And we'll remove that. When you remove the drill bit, if you keep rotating in a forward direction, you'll retain autograft on this. That again help pack into the space that you just decorticated. Then again, you'll then drill out the other few channels. Go ahead and give me another picture. Picture again. Picture again. I'm hitting that pin again, picture. Okay, good. All right. And then we'll drill out the 3rd channel with the inferior space. Picture. Picture. And picture. And you can see how it's fully deployed and it still has not violated the alar line. So now you should be able to get fusion across all 3 segments. So your system will take the autograft off the drill bit, prep things for you while you're doing the rest of the procedure. After you've taken the drill guide out, then you're going to put your box cutter in.
And this is doing a lot of the decortication.
Yep. Right. So we're churning up the bone surface, exposing the blood supply, removing the cartilage off the surface of the bone.
Picture.
Now this box cutter is going to kind of finalize the prep space that we created, and it also does a great job of pulling everything out with it.
Picture. 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 Right, so I'm going to hit the other pin, but this will give you
a little farther.
Yep, exactly.
Because you want, just so I'm getting it right, you want those 2 pins to kind of be right in the middle of where that box cutter ends up, right?
Exactly.
You want to put the screws in the area that you're decorticating.
Right. You want to get compression along the fusion bed.
So at this point,
you'll have more autograft off your box cutter.
Yep. So at this point, we can use some of the same instruments that we use to deliver our cortical graft implant. In this case, we're going to be filling the joint space with a flowable graft. Why are we using a flowable graft instead of a cortical graft implant? Because of those coding changes that specify a structural allograft. That's going to be part of the new T code that's going to take effect on January 1st. So instead of that cortical graft, we're going to fill with a flowable.
And then after you fill the space with a flowable, you want to make sure that you get good contact along the surface area of this joint space. So then you're going to use a tamp. This tamp has measurements to see how far you fill that space. So when you fill this up with graft, and then you put the tamp down and you pack it in, you'll be able to measure how much volume that you fill that space with. Okay. All right. And so you'll mix your autograft with some additional allograft that's flowable, and then fill that. Then after you've done that portion, then you're going to go ahead and remove your instrumentation out, and then you're going to focus on the fixation portion. So then you're going to go to that lateral view, and then after you get the lateral view, then you've already marked out the borders of the alar line, the posterior and ventral sacral line, and marked it out. Your entry point tends to be in the skin, a little bit closer to in the skin where the sciatic notch is, and then you're going to aim your instrumentation to make contact with the ilium just at either at the ventral line or slightly anterior to the ventral line, and you're going to aim for the intersection where the alar line and the dorsal line hit. So you're going to aim for this corner over here. Picture. So find the picture again. Picture. So closer to that point, that's going to be the intersection of your dorsal line and your alar line. So we're going to aim for that first screw, and again, you should then be able to take that over the S1 segment. So you first are going to tap that in, don't advance it too far, then you're going to check your inlet and outlet views to make sure that you're in a safe plane. So if you can go to your inlet view.
So the goal again here is to fixate at the point of articulation in the SI joint, which is where we also create that fusion bed.
25 degrees.
So these pins, are these through the joint yet, or?
Yes,
they're already
the first pin I put through the joint.
Perfect.
And the second one, just for demonstration purposes, we just advanced it. So now that first pin you can see crosses the joint line. I had already advanced it. That second pin is also going to go across that joint line, and the trajectory is not going to violate the anterior margin. Okay. If you look at your outlet view, then you can tell where you're aiming. Now you'll have some patients where they have dysmorphism of the sacrum, and that alar portion is missing, so you may have to sometimes aim at the S1 frame and to have enough room. Okay. But otherwise, if you have a more normal appearance, you may have enough room to get the first screw above S1, and then the second screw between S1 and S2.
So we want, okay. So that second pin, we're going to bring a little bit further in.
Yeah, and I want to show where our entry point for the second pin. We'll first do is focus on the first pin. We've advanced it. Then we're going to place our first dilator over here. So you're going to make an incision. You want to make that incision in the skin the same direction where you're going to end up potentially placing your second screw.
So one incision is going to end up being for both.
Exactly.
You can do, yeah.
So usually my incisions are like 1 inch, sometimes 1.5 inches. Okay.
Okay.
Then again, you're going to advance your first dilator until it makes contact with the ilium. Then you're going to have a second dilator. And you're going to place that over there.
This is very sequential dilation like we use with any other dilator tool.
Yep. And since the resistance on the smile is a little bit more.
You gotta get some counter pressure here.
Right, so then once the dilators are snug, you want to measure what the length of your screw is going to be. So you advance the pin to the depth that you want. There's a tool here that will fit across both dilators. There's measurements on here. They're going to be a little bit dark that you can see on the camera right now, but there's markings on there. There's a black line on your pin. And then, no, this is the fit. Yeah, I'll fit over above, but we can take the first time. Take a picture again, make sure the pin didn't. Okay, right, so now we go ahead and advance this. And now we're going to make sure that this tool is now snug against the dilator. The dilator has to be snug against the ilium, so that way you're at the proper depth. Then you're going to see where the black line lines up. And when this is going to line up right now, we're getting a measurement that's between 40 and 45 millimeters. We don't want to extend too far and encroach the frame, and so we're going to go with a 40 millimeter length screw.
So the screws come in 9 different sizes, starting at 30 millimeters and then all the way up to 70 millimeters.
Now the other thing is that because we already filled the joint space with a graft, we don't want to pull that graft out. So if I went with a larger screw and I had to drill there, when I remove the drill bit, I may remove some of that graft. So to avoid that, if we use a self-drilling screw, then we're going to not disrupt that graft. So this 7 millimeter screw is a self-drilling screw.
So there's no drilling, it's just the screw?
Yeah, just the screw.
Very interesting.
It's a 7 millimeter diameter, which is relatively smaller than most of the other SI joint fusion.
And right over the pin, so the pin never comes out.
Then you're going to advance it.
I see the picture.
Picture.
Nice. And you're not giving it that much torque either.
No.
It kind of just goes on.
Now you'll have some patients where, if they're relatively younger and the cortex is really hard, then you may need power to help you advance it. But otherwise, usually a manual driver, especially in your older patients. Now, what I usually do is I'll get close to the joint line, then I always take images to make sure that trajectory is still safe.
Doesn't move, yeah.
So that make sure you aren't going to violate, so you're going to check your inlet and your outlet views. Go back to your lateral, make sure that you haven't leaned it so you would violate the alar line. And once you confirm that, then go ahead and you can cross the joint line and then take it down to the depth that you need to.
That's right. I think that's a big point. We talk about that a lot. Take the extra pictures. We don't do it here just because of time constraints, but there is no time constraint in the ASC. An extra 3 minutes can go a long way for a good outcome.
Yep.
So I like that we brought that up.
The instrumentation for the screws is very simple. It's just about understanding where you are.
Great. So now if you actually stay in your outlet view and then you go to it, keep like that, 15 degrees, then you'll be able to see the wall of the ilium better. And that way you know whether you've actually engaged the head of the screw into the ilium wall.
Oh, yeah, look at that. So that lateral edge there of the ilium.
Right.
So you want to take that all the way up to the end of the ilium?
Yeah, so that you have threads in the head of the screw, so you want to engage that to get the compression force. Okay. And then as you're advancing the screw, sometimes your pin may advance with it, so sometimes you may have to pull the pin back. And then after you're done, then you can go ahead and take this out. And then you remove the pin.
And the dilator just comes out?
And the dilator comes out. Then you can take an image of where your screw is. Okay. Then you can take your other views. Once you go to a neutral outlet, so just go back to the regular outlet view. That'll give you a better idea how far across the joint you shoot. Okay, so now you're across the joint. Then you can go to an inlet view.
And with the second screw, very similar technique. Exactly the same, right?
Yeah, it's just a position that we'll talk about in a second. So now you can see here the screw is going across the joint line. Okay, if you go that angle at 15 degrees, now you can actually see the joint line. Okay.
You're safe.
Okay, so now we're safe, we haven't violated anything, and the screw actually is going across the joint line there. Go back to a lateral view then.
So that's a 40 millimeter screw.
Most
As I mentioned, it can go, we have sizes ranging from 30 all the way up to 70. The majority of the lengths that we have are typically 35, 40, 45. Perfect. In comparison with a posterior or oblique, you're typically going to be running, to my understanding, about 60. So it's a shorter length.
So just for time constraints, why don't we get that second pin in there? And then it's the same technique for the screw, correct?
Yeah. Are we planning to do a second one?
What I want to do is I'm going to show the point where the artery normally runs and where we're working. Picture. So picture again. Picture again. Picture. Picture. Too far. Picture again. Picture. And picture. And picture again. So this portion here at the border of the sciatic notch is usually where the SGA originates from. And it usually will go into a more anterior branch. It's usually out of the way from your instrumentation. But the few people where it'll go more posteriorly, you're more at risk of hitting it well, especially when you're trying to place something at the S3 segment. So right now, if you just place 2 screws, so that way you avoid rotation, you'll get a true fixation, and then you make your entry point on the skin. So if you look at where I placed this second pin here, you want to make contact with the ilium, typically at that ventral border, and then you'll go ahead and advance that, and then you'll look at your outlet view to make sure you're aiming between S1 and S2, and then advance from there. And then the rest of the steps are the same. You place the dilators, you can measure, and then put your self-threading screw, and then you're done.
I think this is great. I mean, this is just coming to market, I think. You know, it's very much in line with the original SI fusion approach of the lateral view. I love the decortication. It makes sense, right? It makes sense for fusion. It's innovative. I'm very excited. Thank you guys very much for coming and showing us off. This is beautiful. How can someone get a hold of you, get set up, or get a hold of you guys to kind of work with VYRSA and work with the system?
You can go to our website, www.versatech.com. You can reach out to us on LinkedIn, reach out to Dr. Panchal. Right now we are offering a preceptorship for physicians that are interested in transitioning from the posterior to the lateral approach. And that's going to entail didactic sessions, cadaveric training, but also the ability to shadow some of the physicians that we work with, such as Dr. Panchal. We have orthopedic surgeons, neurosurgeons, interventional spine physicians that have been performing the lateral approach for many years, and we're here to assist you.
It's an exciting space, exciting device that's out, and thank you very much, guys. Thank you so much. It was great. Very, very informative. It's the first time I've seen the full lateral view. I'm excited to get it in my hands and see what we can do with it.